Dr. Mehrdad Nadji is a diplomate of the American Board of Pathology in Anatomic and Clinical Pathology and holds the specialty certificate in cytopathology. Dr. Nadji's areas of research interest include diagnostic and predictor biomolecular markers of human solid tumors. He has authored or co-authored more than 200 scientific papers and 15 books, chapters, and monographs. Dr. Nadji has served on the editorial boards of 12 pathology and cancer journals. He has represented the University of Miami as an invited speaker in more than 300 national and international scientific meetings. So it is a real pleasure and honor to bring to our microphone today Dr. Nadji. Welcome.
Thank you very much, ladies and gentlemen, and depending where you are, good morning or good afternoon. Thanks for taking time and participating in this educational activity. The topic of presentation, as you can see, is genomically derived antibodies in diagnostic immunohistochemistry. And the reason for that is that these molecular techniques in the past 10 to 15 years have increased the utility of genomically derived diagnostic and predictive biomarkers. And today, particularly, our discussion will be limited to the diagnostic markers, as the field of predictive biomarker is rather vast and requires a separate session. So with that in mind, let's just start. I believe this is provided by the sponsor. And the area that it says Dr. Nadji has been compensated for this, I want to make sure that you know that I was compensated not by myself, but by the University of Miami Department of Pathology, because I'm on the company time now. Thank you. All right, this is the presentation outline. Outline is how, what, and when. And by that I mean how these proteins were discovered, what are we detecting by using this technology, and when do we use them in our daily practice. And as an example of that, I'm going to show you illustrative cases, some of the common tumors where these markers were used. And I will finish the talk with the values and limitation of all these technologies at this time. This is my disclaimer, and that's that I have no interest, financial or otherwise, in the content and material presented in this educational activity. The immunohistochemistry that we use with genomically derived antibodies, we have to know how these proteins are discovered first. As opposed to classic methods of producing antibodies, which normal cell and tissue proteins were isolated and antibody was produced against them, the genomically derived antibodies take advantage of molecular abnormality detected, and those molecular abnormalities may or may not result in expression of an abnormal protein or an abnormal expression of a protein. That's where we go from here. These are all discovered by expression profiling, either gene amplification, gene translocation, and other genetic abnormalities, gene fusion, and gene mutations, which produce proteins that we can take advantage of them and use them in immunohistochemistry. So what are we detecting is basically very simple. is protein overexpression and protein loss or underexpression, or the product of the abnormal proteins such as fusion and mutated protein products. Where do we use them? A large number of these genomic derived antibodies are used as actually predictive markers. In fact, it all started in the area of predictive medicine, and they were presented as the so-called companion test for a number of targeted drugs. They are occasionally also used for prognostication. What we have been discussing today is diagnostic use of these markers for either tumor diagnosis or tumor classification. And I have to mention to you that the diagnostic markers, that means tumor diagnosis versus a benign or normal lesion, is very uncommon used for immunohistochemistry of these markers. These markers, with rare exception, are basically all used for tumor classification and cell lineage identification. Before I start to give you examples of these usages, I would like to share with you how I'm going to approach with this case examples. First, on the left upper corner is the name of that particular marker, and if available, the abbreviation for that name, where this name is coming from. And then I'll take you into the mentioning the type of protein product, how it was produced, whether or not it is expressed in normal tissue, and the main practical application, at least in my experience, and other potential uses and sometimes abuses. Let's start case examples with those markers that show protein overexpression. And there are a whole bunch of them. By the way, the examples I give you today are just the tip of the iceberg. There are hundreds of these particular markers now available, and we use them on a daily practice of diagnostic pathology, but I can just share with you a few of them. And what a better place to start than with DOG1, which is known to a lot of us. The naming for that comes from discovered on GIST1. It was discovered by gene expression profiling. And the staining is in cytoplasmic and membrane staining, which is unusual. Usually, most of these, as we can see later, are nuclear antigens. But this particular one is actually cytoplasmic and cytoplasmic membrane antigen. It is expressed in a large number of gastrointestinal stromal tumors, more than 95%. The importance of this marker is that it is expressed in KIT-negative gastrointestinal stromal tumor, the one which are related to PDGFR abnormality. Occasional other tumors also could be positive, such as chondroblastomas, and a few epithelial tumors which may be actually focally positive for this particular marker. An example is staining. These are two hematoxin and eosin photomicrographs of the gastrointestinal tumor with some epithelioid features, low and high power. And on the right side, you can see the staining for DOG1 in the cytoplasm and cytoplasmic membrane. Similar to KIT, CD117, the reaction for DOG1 is usually diffuse and the so-called all or none phenomenon. focal staining in these tumors are very uncommon. Give you an example of how it may prove to be very useful. Here is a biopsy of a gastric ulcer. The patient was bleeding, and the clinician felt that there was an underlying large mass protruding through the mucosa and causing this ulcer and bleeding. On this biopsy, it's very difficult to see anything different except the inflammatory cells and so forth. But paying attention to this particular area in the middle of the center of this particular biopsy, there are some nondescript cells which could potentially be an epithelioid gastrointestinal stromal tumor. And hence, with that clinical differential diagnosis, we performed a kit or CD117, and that area, as you can see, is clearly negative. And the epithelial nature of that area is much better seen on this kit staining. However, the staining for DOG1 clearly demonstrates that the tumor is actually an epithelioid gastrointestinal stromal tumor, which proved on the resection of the tumor to be the case. I'm going to go to the next category of these markers, and the one that I found very useful many times is SATB2. This is a special AT-rich sequence binding protein 2. This also was discovered by protein expression profiling. It is expressed normally in epithelium of lower GI tract, colon, and occasionally appendix. The great majority of colorectal carcinoma is stained positive, and the marker, of course, is a nuclear marker. Unrelated, but interestingly, is also expressed in a number of osteosarcomas. As you know, osteosarcomas normally don't have too many markers so far, but this is going to be useful for us. A particular use of this SATB2 is in those rare cases of colorectal carcinoma which are negative for CK20 or sometimes even for CDX2. And that includes the rare medullary type of colorectal carcinoma and occasional high-grade neuroendocrine colorectal carcinoma, which look like a small cell carcinoma. These two may be CK20 negative, but in order to prove their colonic origin, SATB2 will be very helpful. Here on the top, you can see two low and high power magnification of this particular distal colon tumor. It looks like a small cell tumor. On the bottom left, you can see cytokeratin staining, which has a typical staining pattern for a small cell malignant tumors, punctate type of staining. Next to that, in the middle, synaptophysin. It shows that this is indeed a neuroendocrine tumor. However, cytokeratin 20 next to that is completely negative. Now the question is, this is a metastatic tumor, or is it actually colorectal in origin? So here is SATB2 low power and high power showing a diffuse nuclear staining universally for that particular marker. Extremely helpful in these kind of occasions. This next slide shows an interesting case of sarcomatous carcinoma of the lung, or the so-called carcinosarcoma of the lung, also known as metaplastic carcinoma of the lung. The epithelial component of the tumor not shown here was a poorly differentiated squamous cell carcinoma. The mesenchymal component was a sarcoma with focal evidence of osteoid formation, as you can see with the red arrow there. And that area made us to believe that maybe the rest of the sarcomatous elements are also an osteosarcoma. And using this marker, you can see that almost all the tumor cells are positive for nuclear expression of SATP2, including that area which look like osteoid. So not having too many markers for osteosarcoma, this may be very helpful for that differential diagnosis unrelated to colorectal cancer. The next protein is SF-1, is a stereogenic factor 1. This is a member of nuclear hormone receptor family, just like the other that we know, like ER, HER2, etc. Important for differentiation of stereogenic tissues, and is expressed, as you expect, in adrenal cortex and adrenocortical neoplasms. We have plenty of markers for adrenal cortex and adrenocortical neoplasm, which are fairly specific, so we really don't need that for that particular differential diagnosis unless in unusual circumstances. But this is also expressed by gonadal sex cord stromal tumor, as these tumors are also mainly estrogenic. Where it is most helpful is actually in some of the granulosa sertoli-Leydig cell tumors with unusual morphology, which may or may not stain for the common forms of the markers such as inhibin and calretinin. The hematoxin and eosin slides on the top show a cystic granulosa cell tumor of the ovary, which was negative for inhibin. That was unusual. The calretinin was positive focally. In order to validate this diagnosis, we use the SF1. And the staining, as you can see in the nuclei of many of these tumor cells, therefore this was actually a cystic granulosa cell tumor with which was negative totally for inhibin. My favorite marker is this marker, brachyury. And I have no idea where the name is coming from. If somebody knows, I'd be happy to hear from you. It is a transcription factor of T-Box family. It is important for development of notochord and is not expressed normally in any cell or tissue. And you know notochord is the one which is precursor to spinal cord and whatever, spinal column and whatever is around it. And that's why this particular marker is a great marker for most of the chordomas. Almost all of them are stained for chordoma, for brachyury. And it's also particularly helpful in unusual variants. And as you know, chondrosarcomas are sometimes in differential diagnosis of chordomas, but chordomas positive for epithelial markers, chondrosarcomas are not. Therefore, in that differential diagnosis is less helpful, but it could be helpful when you have unusual form of chordomas that one does not think about a chordoma, or there is no clinical evidence to think about it. In addition to the chordomas, they could be positive in some epithelial tumors. The staining, however, in those few epithelial tumors is very focal, whereas the nuclear expression in chordomas generally is universal. The hematoxin used in slides on the top of a paraspinal tumor on T4 And frankly, by the hematoxin using a stain slide and the location, we were thinking of either hepatocellular carcinoma or even a renal cell carcinoma with that morphology, and neither of them actually reacted for the usual markers. And however, as you can see, cytokeratin staining was positive, so it was an epithelial tumor. I don't know what prompted us to use brachyury in this case, but I believe it was probably the X-ray finding which suggested that. And here is the nuclear staining for brachyury in this unusual form of chordoma, supporting that clinical and finally the pathological impression. Now, if you want to see some unusual ones, look at these two slides up there, which are actually metastatic chordoma in lymph nodes. And without any clinical history, it would be unlikely that anybody can think about them because it doesn't have the usual morphology of chordomas. And chordomas in lymph nodes are not that common entity. However, the staining with knowledge of clinical history proved that, yes, these tumor cells are basically positive for brachyury and they are metastatic chordomas. The interesting thing is that in original description of brachyury said is negative in dedifferentiated chordomas, but we have had at least 2 examples of dedifferentiated chordomas which proved to be positive for brachyury. So again, is an extremely useful marker for that differential diagnosis when it arises. Another useful marker protein is SAL-like protein 4, also known as SAL4. This is a transcription factor important for embryogenesis, and that's why nuclear expression is seen in many embryonic tissue. In adult tissue, however, it is not present except for the gonadal germ cells, and that's the only place you find them. Tumor-wise, the nuclear expression is seen in most malignant germ cell tumors. Please remember that it is not expressed in benign germ cell tumors such as mature teratomas. Now, there are some high-grade carcinomas that may show positivity for SAL4 occasional cells, and that is probably for the embryonic stem cell type of reactivity of SAL4, as you know, is involved in embryogenesis, so it's not unusual to think that this marker could stain some embryonic stem cells in some high-grade tumors, not present in usually low-grade tumors. Now, I share with you this particular case, which was very difficult. There's a core small biopsy of an abdominal mass in a young individual. I believe it was a male, and it shows some connective tissue, what appears to be inflammatory cells here and there. And on the top part of it, one can see areas which look like clusters of cells, and these clusters of cells could be anything from lymphoreticular cells to carcinoma cells to sarcoma cells, etc. All are markers for lymphoreticular and epithelial cells were negative. Since gastrointestinal stromal tumor was in the differential diagnosis, we used CD117, and many of these cells are stained, as you can see. As you know, CD117 or KIT is also a marker for germinomas in general, seminomas and dysgerminomas, which are keratin negative. They're also PLAP positive and D240 positive, but SAL4 positivity of the nuclei as you can see in the right lower corner, identified them as actually tumors of the germinoma origin. Another marker which has been very useful also in differential diagnosis tumor is NKX3, is a big family, is a prostatic tumor suppressor gene, is a transcription factor located on chromosome 8, plays an important role in prostatic development. It is downregulated in most prostatic carcinomas. However, is actually nuclear expression can be seen more than 95% of prostatic carcinoma. Is a very good marker for prostatic carcinoma. Rare expression is reported in some androgen-driven breast tumors. Occasional lobular carcinoma of breast have been shown to be positive for this one, or none of them normally are in differential diagnosis of prostatic cancer, fortunately. We have the hemotoxin ionizing slides of a poorly differentiated prostate cancer in a bladder, as you can see. It's very difficult to say is urothelial or prostatic in origin. Prostatic specific antigen, or PSA, is a fairly specific marker for prostatic carcinomas, but it may not be as sensitive. It may be focal staining of particularly poorly differentiated tumors. And in a small biopsy, therefore, it could be potentially negative. The NKX3, however, is normally universally expressed in tumors of the prostate origin, regardless of degree of differentiation, and is also very helpful in metastatic areas, such as this case, which was a rectal tumor, and it showed like a poorly differentiated carcinoma in the rectum, which in a male, I always tell our residents to think about an extension of a primary prostate to rectum, and of course, this kind of poorly differentiated tumor could be of colonic origin. This was CK20 negative, also SATB2 negative. PSA was positive, as you can see, but NKX3 positivity was basically universally staining all the nuclei of a tumor cell. It's an extremely helpful marker in that differential diagnosis. The next category of the case example includes those which we take advantage of protein loss or underexpression in tumor to come up with a differential diagnosis. To start with, this is one of the most useful one, which is INI1, integrase interactor 1. This is a tumor suppressor gene product. The nuclear localization is seen in all normal cells. There is loss by gene mutation or chromosomal deletion in a few tumors, and those are the ones which we can use this particular marker very effectively. It is lost in all malignant rhabdoid tumors by mutation, whether the rhabdoid tumor is renal or extrarenal, doesn't matter. It is a very good marker. The other tumor that this proves to be extremely helpful is atypical teratoid rhabdoid CNS tumors. And these tumors are uniformly negative for INI1. This also can be lost in some epithelioid sarcomas by deletion, and occasional loss in some other tumors, which usually is focal loss in these tumors and not a universal loss, as you can see it in the rhabdoid tumor or teratoid rhabdoid tumors. This particular example is a malignant rhabdoid tumor, which was not renal, it was extrarenal mediastinum. And you can see the loss of a nuclear reactivity for INI-1, your internal control, which are the endothelial cells of capillaries, and also some host lymphocytes are positive, whereas the tumor nuclei are completely negative. A good example of when the loss of antigen helps in the differential diagnosis. Another one of these is BAP1, which is BRCA1 associated protein 1. This particular marker is a suppressor gene product, and again is a nuclear stain. Loss of expression is either by somatic or germline mutations. Somatic mutation is not uncommon in melanocytic tumors, and also where we use it usually is in malignant mesotheliomas. This is particularly helpful in fusion cytology with understanding that the sensitivity is not 100%. I would say about half of these proven malignant mesotheliomas, whether in tissue or in cytology, may be negative. Occasional expression is also seen in some tumors, such as clear cell renal cell carcinomas. And give you an example of this particular marker. In fusion cytology, from the cell block, you can see that those abnormal cells are showing nuclear and cytoplasmic reactivity for calretinin. And then when you use your BAP1, you can see the nuclear loss, which favors malignancy. But I can tell you that it is not as a clear staining. You can have some areas that there are cytoplasmic staining for this particular marker, which should not be considered as evidence, because cytoplasmic marker is not valid as a true loss of the nuclear antigen. So there is a nuclear loss of this particular antigen, which is useful. In absence of that, of course, we cannot be positive about it. It is somehow helpful, but it is not a very sensitive particular marker at this time, at least with the antibodies which are now available. Also share you a little interesting case, as you can see in the hematoxylin and eosin slide. This was a solitary fibrous tumor of pleura. It was a very large mass, and on the right side of it, you can see a number of glandular structures. The question was whether this is an adenocarcinoma there, or is a malignant mesothelioma involved in there. And of course, solitary fibrous tumors, you know, the marker for that is STAT6, which we're going to shortly discuss. But you can see that those glandular structures in the lower right are negative. Then to see whether these are mesothelial or not, calretinin was positive in these, but BAP1 positivity universally in all these glands showed me that this is really a reactive process and not a neoplastic process. And as you can see, every cell is positive, including the stromal cells. Now, a case example related to abnormal protein products, such as the fusion proteins. These are a large group of markers. We're going to start with FLI1, which is friend leukemia integration 1. It's the ETS family of transcription factor, nuclear expression in normal endothelium as your control, expressed in more than 95% of Ewing sarcomas PNET by fusion, of course, the EWS and FLY1. Is also expressed in a great majority of endothelial tumors. And there is a weak expression in a few other tumors. Sometimes when you're dealing with a small biopsy such as this was a neck tumor in a patient who already has a diagnosis of vascular malignancy of known nature that came to us with this particular tumor, which was not very well preserved. And I can tell you that when dealing with endothelial markers, CD34 is really neither specific nor sensitive enough for this particular tumor. CD31 is to some extent specific, but also reacts with some hematopoietic cells. So, for example, if there is inflammatory exudate or lymphocytic exudate indoor, you can find that to be positive and makes the interpretation of result fairly difficult. ERK also, as a marker for endothelial cell, is not that specific. Factor VIII related antigen is more specific, but unfortunately is not as sensitive. The reason I'm mentioning that in this particular case with that history, the other markers were not helpful, but we had sort of a punctate staining for factor VIII related antigen that those arrows will show you next to the nucleus of many of these cells. And we have described this entity many years ago in one of our IHC atlases that I share with you, this photograph. As you can see, there is a paranuclear staining punctate pattern for the factor VIII in a high-grade angiosarcoma. But with the availability of the FLY1, one can use this one and is a clean, as it could be, nuclear staining, as you can see in the almost all the tumor cells in this particular small biopsy, which was otherwise very difficult to interpret the results. As I mentioned, in addition to endothelial tumors, PNET can be positive. Ewing and PNET can be positive for FLY1 in more than 90% of the cases. And this is particularly useful in the areas which are not commonly PNETs are seen, such as this one in the wall of the uterus. And positive for FLY1 confirm that diagnostic impression, which was also confirmed by CD99, etc. Molecularly, of course, these can be easily confirmed by molecular techniques. The next one that we mentioned shortly was STAT6, is a signal transducer and activator of transcription 6, is a somatic fusion of NAB2 and a STAT6 gene. In more than 95% of solitary fibrous tumor, this can be seen. Is also expressed in some differentiated and some dedifferentiated liposarcomas, and occasionally other soft tissue tumors. Interestingly, in solitary fibrous tumor, the reaction is limited to the tumor nuclei, whereas in other tumors, it may be in both cytoplasm and the nucleus. Here is an example of a solitary fibrous tumor of the actual orbit. And our old immunohistochemical stain for that particular tumor was CD34, which is universally positive. Now with STAT6, you can see a nice nuclear staining of almost all the cells in this confirming that diagnostic entity. One more of these particular useful markers is TFE3, transcription factor binding, enhancer 3, etc. This again is a nuclear expression in tumors with TFE3 fusion. Interestingly, it's expressed in some of the rare renal cell carcinomas with XP11 translocation, and is also expressed in a small subset of pecomas. The main use of it is in alveolar subpart sarcomas, in more than 95% of them. As you know, alveolar subpart sarcomas do not have, so far, a very reliable immunohistochemical marker. Usually the diagnosis is by exclusion. The availability of this marker has increased our efficacy of diagnosing this entity. The expression of this particular protein is diffuse in alveolar subpart sarcomas and also in those rare cases of XP11 renal cell carcinomas. Let me share with you two cases. One of them was actually a primary alveolar subpart sarcoma in bone, which is not a common finding. The staining for TFE3 supported that particular diagnosis among the whole host of other markers that we use to identify this. First, we thought it was an epithelioid malignant tumor, which was shown that is really not, is a sarcoma. TFE3 positivity proved that this is an alveolar subpart sarcoma, although it is a very difficult differential diagnosis. The next case is lung excision of a tumor mass in a patient who already had the diagnosis of alveolar subpart sarcoma. And the alveolar subpart sarcomas, as you can see, are very epithelioid. And one has to rule out carcinoma of the lung, which is more common, of course. And as you can see in the lower corner, tumor is clearly negative for cytokeratin cocktail, whereas the lung tissue is positive. With that clinical history, TFE3, you showed that tumor cells are uniformly positive. The nuclear staining confirming that metastatic alveolar subpart sarcoma in the lung. Now, TLE1 is a transducing-like enhancer of SPLIT1. This one also was discovered by gene expression profiling. In more than 90% of synovial sarcomas that have the SYT-SSX fusion is seen. The nuclear reaction is strong and diffuse in tumors. Less common and weak expression seen in solitary fibrous tumor and hemangiopericytomas, and occasional expression in epithelioid sarcomas. It's interesting when this, like any other marker which is described, first was supposed to be a very, very specific marker for synovial sarcomas, and then larger and larger studies showed that that is not true. A number of other tumors can be positive. Therefore, it necessitates the use of all these markers that we discuss in a panel. Of course, addition of these markers to the panel helped us tremendously because we didn't have these before several years ago. This is an example of a synovial sarcoma with hemangiopericytoma pattern. These tumors can be focally positive for cytokeratin and EMA, and normally they are also positive for BCL2 and CD99. So that's where the question came that whether this particular one is a synovial sarcoma, and TLE1 positively seen in almost all the nuclei of the tumor cells. So this marker have helped me personally a lot in some of the unusual tumors in unusual locations, particularly in the soft tissue of the younger adults. That was the good news. The bad news is this is an inguinal tumor in a lady, which by hemotoxin and eosin, it looks like smooth muscle type of tumor. And we confirmed that actually by staining positive for caldesmon and desmin. So there was no question that this is a leiomyosarcoma in that area. But as you can see, TLE is positive in a number of the nuclei of tumor cells, not universally, but a number of them. And of course, that has to be taken into consideration that this particular marker is not truly specific for synovial sarcomas. Finally, the mutate protein products. IDH1 is the isocytosine dehydrogenase 1. Mutation are all at codon 132. The antibody is against the mutation-specific protein. IHC is reported actually by some that is more sensitive than sequencing the gene. Mutation is common in low-grade gliomas, and that's why we have a problem with non-neoplastic gliosis. Those are always negative. And the diffuse gliomas, as you know, sometimes in a small biopsy are very difficult to differentiate from gliosis. And this particular marker helps in that differential diagnosis. In fact, some of the higher grade gliomas can also be positive for IDH1, and those are the ones which can have a better outcome actually. And that's one reason that IDH1 now is routinely performed on all the gliomas regardless of degree of differentiation. And here is an example of the low-grade diffuse astrocytoma positive for IDH1, nuclear and cytoplasmic. And here is a higher-grade tumor which is negative in the lower corner. I'd like to finalize this talk by tell you why do we do immunohistochemistry as opposed to molecular technique, where most of these particular abnormalities are actually genomic abnormality. So, first of all, similar to molecular techniques that use for differential diagnosis of these tumors, the genomic abnormalities are also shared. It's not specific for a specific tumors as we always thought it is. Therefore, the protein product also, so immunohistochemistry with these antibodies is almost as sensitive as specific as the molecular technique. Not always, but sometimes is actually as sensitive, but definitely as specific. The turnaround time is extremely important because this allows us to do this test much faster, and of course is going to be much cheaper. But the very important issue is availability of tissue for doing this test. And as you know, that the molecular tests require a considerable amount of tissue or tumor volume for testing, whereas by immunohistochemistry, few tumor cells can give us some clue about their line of differentiation. And finally, to us pathologists, immunohistochemistry is more familiar than molecular technique, and also molecular technique are not always widely available in a number of institutions, and they have to be sent out, et cetera, et cetera. So overall, this immunohistochemistry can be very helpful, but is not going to be replace molecular and a number of circumstances. What are the limitations? Most genomic alterations, you have to remember, do not have protein product markers. On the other hand, proteins can be expressed without gene abnormality. And as I mentioned, questionnaire results have to be confirmed by genomic assays. So that's a given. Also, as we discussed already, consider overlap exists in protein specificity, variation in antibody sensitivity and specificity. Each clone may have its own sensitivity and specificity, so we have to be careful. I also want to caution you, when you're reading the paper, of those papers which studies of these markers are based on tissue microarrays. As you've seen, many of these tumors actually express the antigens focally. Therefore, a small sample on a tissue microarray may be negative and falsely negative, and you get larger samples of the tumor may be positive. So then the specificity of these particular markers become less as what is reported in the literature. So the final message for this particular talk is the immunohistochemistry for this genomic derived antibody should be used always in panel. It's no different than any other markers that we use for diagnosis. So these are helpful, important, but again, it should be used in the panel, not as solitary agents. I want to acknowledge the colleagues who keep me honest by sharing their challenging cases. Many of them are in a consultation received here. Some of them I was able to resolve. Some of them I've not been. But I was happy to be able to share it with you. Now, we talk about the negative aspect of genomic alteration, like cancer, etc. Now let's see an example of positive genomic change. This young Persian came to our house when she was 8 weeks old. She is now an elegant and beautiful 15-year-old lady. As I don't have the picture to tell you, I also tell you that she's also sometimes a pain in the neck. I left my email address down there for those of you who want to contact me with your comments or criticism. I appreciate to hear that sincerely. And I thank you once again for your attention and the time spent on this particular exercise. Thank you.
And thank you so much, Dr. Nadji, for a wonderful presentation. I'll leave your cat picture up here for just another few seconds before we move on to questions. We do have just a limited amount of time for questions, so let's just go right to the first one. We won't be able to take very many, but we'll see what we can get through. The first is, does SATB2 plus medullary type CRC include both MSI unstable and stable tumors? And the second part of this question is, do you have any information regarding MSI status in the CK20 negative tumor you presented?
I can easily tell you no on both questions. I do not have that. That tumor is, by the way, not very common. And I'm sure some gastrointestinal pathologists can answer that better. So I don't have any experience with MSI in these kind of tumors. And that's about it.
Okay, thank you. And then next, and this will be the last question, considering the time here. The last is the heterogeneity of the tumor a limitation?
It is always a limitation. And that's why I brought up the issue of why false negative, particularly in a small biopsies such as tissue microarray, may not be very useful in evaluating a new antibody for its sensitivity. The larger the sample, of course, the better. And however, these markers, same as other markers that we have seen in the past, can be focally expressed. And focal expression of these markers, along with a number of other ancillary markers in a panel, can be helpful. In isolated case, just for single marker, obviously the heterogeneity is going to cause a problem, and that's a fact of immunohistochemistry.
Well, excellent. Thank you so very much. I just want to, we've reached the scheduled end time here, so we're going to need to wrap things up, but I do have some very nice comments here in the chat box for you, Dr. Nadji. Wonderful presentation. Thank you so much. I'd like to make sure that everyone knows that if you would like to submit an educational article for pathology leaders, send it right here to eric.heilman@leica-biosystems.com. Susanna has put that into the chat box, so you can feel free to copy and paste that straight from the chat box. Today's recording will be available within a few days right here. Also, Susanna has just put that link into the chat box as well. Thank you, Sue. So copy and paste that one as well. And bookmark this website if you have not already done so, because there's a wealth of knowledge on pathologyleaders.com. If you'd like to receive PACE credit or Florida Laboratory credit or a certificate of attendance for attending today, the way it will work is when you leave the session, you will close the WebEx window. You'll see the evaluation open in your browser automatically. So you will not see the evaluation until you close the WebEx window, but leave your browser open. Access the evaluation, fill it in, send it right in, and you'll be receiving your certificates of attendance via email within a couple of days if you send it right in. If you wait more than 24 hours, it can take up to 2 weeks to receive your certificate of attendance. Now, for those of you who are joining us as part of a group, whoever has logged in today will be receiving an email from messenger@webex.com. Keep an eye out for that email, please, and forward it to everyone who joined with you today. If you've joined us from a mobile device, you will not see the evaluation open when you close the app, but you will be receiving that email from messenger@webex.com. So if you have joined us as part of a group, if you're the person who's logged in, or if you've joined us on a mobile device, watch for that email and forward it to everyone in your group so that they can access their evaluations as well. Your certificates of attendance, as I said, will be sent via a link in an email within a few days. If you wait more than 24 hours to send in your evaluation, I keep repeating these because we still get so many questions, then it can take up to 2 weeks to receive your certificate. If you have any questions that have not been responded to, or if you have any that come up a little bit later, please send them right here to eric.heilman@leica-biosystems.com. Again, Susanna has put that into the chat box. So a big thanks again to you, Dr. Nadji, for a wonderful presentation and for answering those questions. Thank you so much, sir.
My pleasure.
And a big thanks to our friends at Leica-Biosystems for sponsoring today's event through Pathology Leaders. So thank you to our good friends at Leica. And biggest thanks go to all of you for joining us. We hope you learned something new and hope that you'll join us again for the next Pathology Leaders webinar. So thanks so much. Have a wonderful rest of your day. Thank you, Dr. Nadji. Wonderful presentation.
Thank you.